So my name is Simeon Mitchell. I'm one of the third-year residents, and I'm going to present grand rounds today on new updates in ischemic stroke and TIA. So before we get started, I just wanted to thank a few people that helped me out with my grand rounds. So those are Dr. Stotts from Neurology, who's actually here in the audience. It'll be great to have a neurologist's perspective. Dr. Perry, our local TIA expert, and Dr. Thurger, my supervisor. So let's start off with our objectives. So the talk is divided into two. The first part will be chatting about endovascular therapy for ischemic stroke, try to go over a little bit of the latest evidence, understand why this is relevant to the emergency physician, and how endovascular therapy is changing the stroke code process. We'll then shift gears to TIA, which will take about 1/3 of the talk, and discuss some of the imaging modalities in TIA and how that influences some of the risk stratification. And finally, we'll chat about which TIA patient should see a neurologist before leaving the emergency department. So let's jump right away into endovascular treatment of ischemic stroke. We'll start off with a clinical scenario. So a 69-year-old man presents with right arm and leg hemiparesis and expressive aphasia. You suspect a left MCA stroke. And so what we're going to do is kind of pull the audience a little bit for a few different scenarios. So your management options are kind of on the bottom. So if we say that this patient was last seen well 5.5 hours ago, your options are to call a stroke code, call the neuro senior to discuss on the phone, or just kind of transfer them to OBS. So who is going to call a stroke code? Okay, the vast majority of people. So we're starting off easy. We're going to work towards a little bit harder. So let's say this same patient actually woke up with symptoms, and now it's kind of a wake-up stroke. So who's going to call a stroke code? Okay, so I see a couple of hands. Who's going to chat with the neuro senior on the phone? Okay, so I see maybe the majority of hands. And who's going to send them to OBS? See, no hands. Okay. Let's say this patient was actually last seen well 8 hours ago. So kind of the same management options. Who's going to call a stroke code? Okay, I see 0 hands. Who's going to touch base with the neuro senior on the phone? Okay, I see maybe half of people raising their hand. And who's going to transfer this person to OBS? I see 1 person. Okay. Last scenario, let's say they were last seen well 1 hour ago, but you know that their INR is 5. So who's going to call a stroke code? Okay, I see maybe the majority of hands. Who's going to call the neuro senior? Okay, and who's going to transfer them to OBS? Okay, so we're going to touch base with these scenarios in a little bit more detail throughout the presentation. So to start off, we'll touch base a little bit with the historical view of endovascular therapy. So that we know that people have been doing endovascular therapy for ischemic stroke for a number of years. And this kind of started after the PROACT 2 study that was published in JAMA, which showed some benefit. We know that then there were a number of high-quality studies that were done in 2013, all published in the New England Journal of Medicine, all involving a large number of patients. And actually, the IMS3 Ottawa was actually a site in that study. And the results of these studies were quite a bit of a surprise, because these studies actually found that there was no benefit to endovascular therapy compared with standard therapy, which a lot of people were quite shocked about, because people were doing these procedures and feeling like they were actually making a benefit. And then a few years later, last year, maybe you'll remember, there were all these stories in the media. So there are stories like this. This is a news article from the Ottawa Citizen saying, we're lucky to live here, Ottawa stroke survivor says. There were other articles like this one in the Globe and Mail, new procedure, a major breakthrough in stroke treatment, says Canadian study. And this is actually referring to the ESCAPE trial, which we'll talk about in more detail. And then here's another one from the BBC saying doctors call for wider use of new stroke treatment. So this is quite a big difference from 2013 to 2015, where we're seeing all these news articles. And this is only 2 years later. So 2 years later, there were 5 more randomized controlled trials that were published, which actually had very, very positive results. So these are Mr. Clean, Extend IA, ESCAPE. Again, Ottawa was actually a site for the ESCAPE trial. And then SWIFT Prime and Revascat. And so why was there such a big difference between these studies published in 2013 and then these studies published just 2 years later in 2015? And so we're going to talk about this in more detail, but a lot of it has to do with the patient selection for who's undergoing these procedures, and also the imaging selection for these procedures, and finally the actual technology that's being used in these procedures. So what we're going to do is chat about the ESCAPE trial. We're going to talk about that in a bit of detail because that helps us understand some of the other studies that were done. So in terms of the ESCAPE trial, this was a multi-center prospective randomized controlled trial. It's a Canadian study, but it was actually a worldwide study. And as I already mentioned, TOH was a site of this study. And so the goal of this study was to compare endovascular treatments plus standard treatment versus standard treatment alone. It was open label, but blinded outcome measures. And so what were they looking in terms of outcome measures for this study? It was actually a functional outcome, which we'll discuss. Covidin, which is the manufacturer that makes a lot of these stents, which we'll chat about, provided some funding but wasn't directly involved in the design, conduct, collection, or analysis of results. And so their primary outcome, as in most of these large stroke trials, ischemic stroke trials, was the modified Rankin scale at 90 days. And just to refresh our memory as to what this actually is, it's a scale from 0 to 6 with increasing disability, functional disability, as you go up higher in number. So 0 is no symptoms, 6 is dead. And actually, what a lot of the studies look at is what's called functional independence, which is a score of 0 to 2. Other things that the authors were looking at in the ESCAPE trial was death, intracerebral hemorrhage, reperfusion, and angiographic complications. So we're going to look at the inclusion criteria for ESCAPE, and this is very important to understand the context of some of these studies. So first of all, in terms of patient factors, patients were included if they presented within 12 hours of onset of stroke symptoms. But probably even more important is some of the imaging criteria, the imaging inclusion criteria for patients. So every patient that was randomized in this study had to have a non-contrast CT and a CTA, preferably a multi-phase CTA, and we'll chat a bit about what that actually entails. And so in terms of the results on these imaging studies, there had to be an included proximal artery in the anterior circulation. And finally, there had to be what's called a small ischemic core and good collateral circulation. And these last two criteria is to kind of determine if there's an ischemic penumbra, meaning that there's a core area of infarcted tissue that is not salvageable, but there's a larger area of tissue around this ischemic core, which is potentially salvageable. So if we look at where these lesions actually were located, as I said, they had to be proximal clots in the anterior circulation, so meaning the MCA trunk and its immediate branches, with or without intracranial occlusion of the internal carotid artery. And so why were they using these big arteries or occlusions in these big arteries? And that's, I guess, for a number of reasons, but the main reason is that larger occlusions are easier to remove, and also smaller occlusions are more likely to be lysed with IV TPA. If we look at how did they determine if there's this small ischemic core? I mean, intuitively it makes sense, but how do you actually determine that based on the imaging? And so this is actually evaluated with the aspect score. So this is something that some people are probably familiar with. It's the Alberta Stroke Program Early CT score. And what is this? It's actually a 10-point topographic CT score. So you look at a non-contrast CT head at very specific regions, and you see if there are any ischemic changes. And so you take away points for more ischemic changes. This is actually, as you see on the bottom, actually already part of our stroke code package. So we've actually been doing this, the stroke team has been doing this for a number of years. So this is how you determine the ischemic core. In this study, they defined a small ischemic core as an aspects of 6 to 10. So moving on to the last imaging part, how did they determine if there's good collateral flow to this ischemic penumbra? So that was defined in the study as good collateral as filling of 50% or more of the MCA arterial circulation on CTA. And so this was done, the authors were encouraging people to use multi-phase CTA, which is what we're using here at TOH. And so it sounds very complicated, but when you actually look into it, it's not quite so complicated. All it means is that you're doing a CT angiogram with different phases. So you first do an arterial phase, which goes all the way from the aortic arch all the way to the vertex of the head. And then you shoot two more venous phases that just go from the base of the skull to the vertex of the head. And so by looking at these different phases, you can try to see if there's good collateral circulation. So what was the intervention in the ESCAPE trial? So patients in the intervention group underwent mechanical thrombectomy. They tried to encourage people to use retrievable stents, which we'll talk about what that actually means. And they discouraged, and there was in fact no intraarterial TPA, which is a very big difference from some of these studies in 2013. There were also very aggressive time targets. So the goal of non-contrast CT head to groin puncture was equal to or less than to 60 minutes. And the goal from CT head to actually reperfusion of the vessel was under 90 minutes. So there was a focus in the ESCAPE trial on trying to open the vessel early, which is another difference with some of the older studies, and even a difference comparing the other studies in 2015, which we'll talk about. For example, in the ESCAPE trial, they wanted CT, CTA. The use of MRI was discouraged, whereas in a lot of other studies, MRI imaging was part of that. So what exactly is a retrievable stent? Because I remember we did the Mr. Clean trial at Journal Club, and we were chatting about these retrievable stents, and I had no concept of what a retrievable stent is. So there's actually an animation which we'll try to play, which will just explain a little bit what a retrievable stent is. So basically what they do is they advance a guide wire all the way up to the clot and then actually through the clot. And then you advance what's called a sheath introducer, so something that goes over the guide wire, again through the clot. So this is using a Seldinger technique. You then take out the guide wire, and then finally you're able to pass this retrievable stent through the sheath introducer. And then you pull back the sheath introducer, and as you do that, the retrievable stent actually expands. So once that happens, there's actually flow through the vessel, and then the whole thing is pulled out as a unit. So then you pull out the actual stent, which is in the clot, everything all together, and that's how you recanalize the vessel. So what were the results of the ESCAPE trial? So first of all, the trial was stopped early after an unplanned interim analysis. And we'll see that this is a theme throughout the endovascular trials. So Mr. Clean, which came out first, showed quite a bit of benefit, and that prompted an unplanned interim analysis, which showed efficacy. So because of that, the trial was stopped. This is a modified Table 1, and we can see a little bit the patients that were in both arms of the study. As you can see, the patients in this study had pretty significant strokes if you look at their NIH score. So basically moderate to severe strokes. If we look at how many patients in this study received IV TPA, and so this is always very important for us as emergency physicians because we're basically worried about missing patients that are not candidates for IV TPA but would be candidates for endovascular therapy. And so as you can see, about 75% or 3/4 of the patients received IV TPA in this study, meaning that about a quarter did not. And then if you look at a little bit at some of the times, so the vast majority of patients, they were able to meet their time targets, these very aggressive time targets of groin puncture to reperfusion and CT to reperfusion. If we look at some of the results of this study, so the modified Rankin score of 0 to 2, meaning again a functional independent outcome for patients at 90 days, you can see that the absolute risk reduction is massive. It's very, very impressive if you look at the endovascular group compared to the control. So an absolute risk reduction of 24% with a number needed to treat of 4. ESCAPE was actually the only endovascular study to show a mortality benefit. So not only did patients seem to do better from a functional standpoint, but actually there was a mortality benefit in terms of receiving endovascular therapy with a number needed to treat of 11. If we look at some of the complications, and so one of the complications that we're always interested in stroke trials is symptomatic intracerebral hemorrhage. You can see that there wasn't a large difference between groups. There was a tiny bit more in the endovascular group, but this wasn't statistically significant, and with a number needed to harm of 100. Again, what's really interesting to us is 49 patients underwent randomization after 6 hours of stroke symptoms. Unfortunately, the difference in outcome in these patients that were 6 hours into their stroke didn't show any statistically significant difference, although the trend was towards benefit of the intervention. This is just a graphic representation of the Rankin score in the ESCAPE trial. So you can just see that graphically with the endovascular therapy, people tend to have a better, lower modified Rankin score. And if you actually look at this figure, what they did is they looked at the patients that received IV TPA and the patients that didn't, and you can see that in both those groups, there's still a benefit to the endovascular therapy, meaning that patients that are not IV TPA candidates would still benefit from the endovascular therapy. So now that we've talked a bit about ESCAPE, we're going to talk about some of the other studies. So we already mentioned that ESCAPE was one of those studies. There are 4 other big endovascular studies that were all published either in late 2014 or 2015. And so they were done across the world, involving actually quite a significant number of patients. If we look at, in these studies, did patients always receive IV TPA, or were there some patients that, again, did not receive IV TPA? We can see that 2 of those studies, Extend-IA and SWIFT Prime, everybody received IV TPA. So that means to us that, we wouldn't be missing patients if they weren't TPA candidates. In terms of the other 2 studies, it was similar to the ESCAPE trial in that they included patients that were not IV TPA candidates. And if we look at the time period, this was similar across studies. So patients were randomized if they presented usually within 6 hours. One of the studies, Revascat, actually included patients who presented within 8 hours. So as you can see, ESCAPE is the only trial that included people up until 12 hours. The vast majority of the studies included people to around 6 hours. And so if we look at the different imaging criteria between these studies, you can see that they're fairly different. So as I mentioned, ESCAPE had a large emphasis on CT imaging and discouraging MRI. Some of the other studies utilized MRI. Some of the other studies did not have to demonstrate good collateral flow. And some of the studies used CT perfusion or kind of complex MRI imaging that actually required mathematical modeling and a lot of complicated things, so it's more difficult to standardize across sites. If we look at the type of endovascular therapy that was used in these studies, we can see that the vast majority used mechanical thrombectomy using the retrievable stents that we already talked about. The only one that included some intraarterial lytics was Mr. Clean, which was the earliest of these positive endovascular studies. And so were some of these other studies stopped early? The truth is all of them were stopped early, and all of them were stopped early after Mr. Clean came out. So Mr. Clean came out in December of 2014. It showed quite a large benefit. It kind of prompted all of these other studies to do interim analysis, and then all of these studies were stopped early because of that. And just in terms of some special notes about these studies, we can see that Mr. Clean actually included a few more lesions than the other ones. So in Mr. Clean, they included anterior cerebral artery lesions. And finally, the SWIFT Prime, it sounds like Kavaiden was very heavily involved in terms of planning and analysis of that study. There was recently a meta-analysis that was published in JAMA in November of 2015, and this looked at all the endovascular studies. So as you can see, the ones in blue are the 2013 studies, which didn't show a benefit. The ones in 2015 are the ones in red that did show a benefit, and this just allows us to look at all of these studies together. You can see that this is looking at the outcome of functional independence, meaning a modified Rankin score of 0 to 2 at 90 days. And you can see that, as I had said previously, the 2015 studies strongly show a benefit to endovascular therapy, and the 2013 studies do not. You can see that the I-squared is quite high, indicating a lot of statistical heterogeneity, which I guess isn't surprising knowing the discrepancy in the results. As I said before, the mortality benefit was only observed in the ESCAPE trial. And if we look at across studies, there was no difference in symptomatic intracerebral hemorrhage across all of the endovascular studies. So let's talk a little bit about endovascular therapy here at TOH and how this works. So Dr. Stotts was kindly able to provide some numbers as to the number of procedures and things like that at the Ottawa Hospital. So how many endovascular procedures for acute ischemic stroke were performed in 2015? So the answer is 81. How many stroke codes do we have per year at TOH? What proportion of stroke codes end up getting endovascular therapy? So there's about 400 stroke codes per year, and that obviously includes certain stroke code activations that aren't strokes, like it's a heterogeneous group in there. And so how long have we been doing endovascular therapy here at the Ottawa Hospital for? And the answer is for about 5 years. So again, a lot of academic hospitals have been doing these procedures prior to these studies in 2015 showing a large benefit. Who actually does these procedures? Like, how many people are there at the Ottawa Hospital that do these procedures? And the answer is, like, actually 3 people do this for acute ischemic stroke, which initially seems like a very small number, but Dr. Stotts had a good point. If you compare this to across Ontario, for example, in Kingston, they don't do any endovascular therapy. And if you look at Hamilton, they only do endovascular therapy like certain days of the week. So this is actually quite competitive. And so what about, what we want to know is, will this change the pre-hospital stroke bypass, right? Like now that we've shifted at our institution to 6 hours, is it going to change for EMS as well? And the answer to this is it's a kind of complicated question because this has like provincial-wide implications and has to be addressed at like the medical advisory committee for the province. So if we look at some of the limitations to endovascular therapy and some of the future directions for this therapy, we know that there's now like a very clear benefit demonstrated in a specific patient population. So meaning those patients with large proximal clots in the anterior circulation. There's no evidence yet of benefit for other lesions, really, like smaller lesions or lesions in the posterior circulation. This, though, makes sense because, as I mentioned earlier, the large occlusions are more amenable to mechanical thrombectomy, and the smaller occlusions are more amenable to lysis with TPA. We still really don't know what the upper time limit for benefit is. We know that most of the studies were done up until 6 hours. ESCAPE included studies that went up until 12 hours, but for those patients that were from 6 to 12 hours, there wasn't any statistically significant difference. So this is still to be determined, really. And we can see that there's kind of a shift in assessing people with ischemic stroke from the time last seen well, which for us was always and still is very, very important, to a shift to probably the imaging actually showing if a patient still has salvageable tissue. And so we'll probably see a shift for that in the future. And probably the imaging will partially replace the time last seen well. So in the meantime, what do we do about this now in the emergency department? You're working an evening shift this evening, like what do you do? So we were actually, in terms of polling the group, quite close to what would be expected. And I was discussing with Dr. Stotts, and a lot of this is still an ongoing discussion because of how new this stuff is. But for symptoms under 6 hours, you should definitely call a stroke code. And it's important to note, as I think a lot of people picked up in this room, that this is no longer simply about, is this person an IV TPA candidate? So people that have a very clear contraindication to IV TPA may still benefit from endovascular therapy, and that's important to remember when we're assessing patients. What about if you have symptoms over 12 hours? Okay, this is easy, it's supportive care. There's no evidence at all showing any benefit for endovascular therapy after 12 hours. And this is where it becomes a little bit difficult. Like, what about these wake-up strokes where it's not really clear when the stroke actually started? Or what about symptoms that are more than 6 hours but under 12? And so what would be expected right now is to kind of touch base with the neurosenior and run the case by them and try to expedite the CT and the CTA. Again, because the imaging is going to determine a lot of if this person is actually an endovascular candidate. And so something that I was just thinking, I don't know if we need some way of actually physically doing this. I mean, it sounds easy enough in principle, although it becomes quite a bit of phone calling and also sometimes some arguments with radiology. Like, it's unclear if we could benefit from an analogy, something similar to the code-emerge blood work, if there's some way of just automatically getting this imaging quite quickly. So just in terms of going back to our clinical scenario with the patient with the left MCA stroke, so last seen well 5.5 hours ago, call a stroke code, a wake-up stroke, we should touch base with the neurosenior and try to expedite the imaging. What about last seen well 8 hours ago, so kind of out of the 6-hour window, but not more than 12 hours? Probably we should also touch base with the neurosenior and try to expedite some imaging. And last seen well 1 hour ago, but the INR is 5, which would be like a contraindication to IV TPA. This person is for sure potentially an endovascular candidate, and we should call a stroke code. Okay, so we are now going to shift gears and now chat a bit about TIA and some of the imaging and workup for that. So we're going to start again with a clinical scenario. So you're seeing a 75-year-old woman that presents 20 minutes after an episode of dysarthria and left arm weakness that completely resolved en route to the emergency department, and so you diagnose a TIA. What imaging test or tests, so you can order more than one, do you order and why? So who would order a plain CT head? Like, hands up. Okay, yeah, everybody would probably do that. Who would send this patient home and order outpatient carotid Dopplers? Okay, so we'll see a few hands. And who would do a CTA for this patient? Okay, and then the vast majority of hands. And so we're going to talk about this in a little bit more detail. And so what we have to talk a little bit about is risk stratification in TIA. And so first of all, like, why do we risk stratify people in TIA, and like, what's the point of all this? And so we know that the risk of stroke, recurrent stroke, is quite high after a TIA or a non-disabling stroke. And that risk is actually front-loaded, meaning that, for example, in this one study, 17% of recurrent strokes happened on the same day as the TIA, and 43% happened within a week. So that the risk is actually quite early on. We also know from two studies, the Express study that was published in the Lancet and SOS TIA study that was published in Lancet Neurology, that actually identifying these patients and aggressively treating them actually improves outcome. So that there's actually a point to basically risk stratifying and finding these patients. And so classically we would use these clinical prediction rules like the ABCD to score, which was based on clinical factors, but we know from many studies that these scores actually perform quite poorly. And this is, one of the reasons that Dr. Perry is involved with the Canadian TIA risk score as well. But what about the imaging? Like, how does the imaging results contribute to risk of having a recurrent stroke? So I wanted to talk about this study. This is a study that was published in Stroke in 2015. And so what this study did, was to try to look at the plain CT findings and how that influences the risk of recurrent stroke. I'm sure you probably recognize a number of Ottawa authors on this paper. And so this is a study that was done at 8 Canadian emergency departments. So it's a Canadian study. It's done from the emergency department, so obviously quite useful for us, and involving a significant number of patients, over 2,000 patients with a discharge diagnosis of TIA. And so the CT head that was done on that index visit was assessed by a neuroradiologist and to try to find any signs of ischemia. So that included both acute ischemia, and that didn't have to anatomically fit with the patient's presenting symptoms, but just any signs of acute ischemia, and then as well signs of chronic ischemia or signs of microangiopathy. And so the primary outcome was stroke within 90 days, and the secondary outcome was stroke within 48 hours. And so the way that these outcomes were obtained was through a standardized telephone questionnaire as well as a chart review. The people that were reporting the outcomes were blinded to the initial index visit. And so in this study, because there are different definitions of TIA, there's the clinical definition, meaning that people have deficits which resolve within 24 hours, which is kind of the classic definition. This is the definition that was used for this study. If we look at some of the results of this study, you can see, I guess, a few different things. First of all, you can see that as you increase the ischemic load or the number of ischemic findings on the CT head, you can see that this is associated with an increased risk of recurrent stroke. It's important to note, though, that these aren't just chronic ischemia or microangiopathy. It's important to have signs of acute ischemia as well. Unfortunately, you can see that for the acute ischemia group, the results weren't statistically significant for stroke within 48 hours, but they were for stroke within 90 days. And so as you can see, as you increase the ischemic load, you get stronger and stronger odds ratios. There were some limitations to this study. So first of all, the follow-up was done by phone. 16% of patients were actually lost to follow-up. And as I already mentioned, the results of stroke within 48 hours wasn't statistically significant for just acute ischemia. But we know from this study that basically patients that have signs of ischemia on their CT head presenting with TIA are at increased risk of recurrent stroke. What about vascular imaging in TIA? So why do we do vascular imaging in TIA? I think that there's been a bit of a shift as to why we do vascular imaging over the years. So initially, vascular imaging in the setting of TIA was to really evaluate for carotid stenosis. And so that came about after the NACIT study that was published in the New England in the late 90s, and that showed a huge benefit for patients with symptomatic carotid stenosis over 50%, with an actual decreased risk of recurrent stroke and mortality benefit if they received carotid endarterectomy. So that's kind of why vascular imaging became very important. But we know that now, because CTA is more prevalent, and it's often easier for us to arrange a CTA right away compared to a carotid Doppler. So there's actually more and more patients that are actually getting a CTA to image their carotids compared to just a carotid Doppler. But we know that CTAs generate a lot more information and a lot more data than just carotid Dopplers, because you also image all the intracranial vessels. And so, we'll do that to look at somebody's carotids, but what do we do about if there's significant intracranial stenosis or if there's intracranial occlusions? And how should we use this information to help us risk stratify the TIA patients? And so this was addressed in the CATCH study. So this was a study that was published in Stroke in 2012. It was another Canadian study, so it was done at Foothills in Calgary, and it was a prospective study. And so what the authors wanted to look at was if CTA findings could actually predict recurrent stroke. And so this study involved 510 patients presenting with high-risk TIA or patients presenting with a minor stroke, meaning an NIH stroke score of under 3. And so these patients underwent a CT and CTA, and that was then evaluated by a neuroradiologist. The study also involved a little bit of patients getting MRIs, but I'm not really going to chat about that because that's not as relevant to us in the emergency department. And so then these patients were followed for 90 days, and they were followed to see if they developed a recurrent stroke. And so the way that it was determined if these patients had a recurrent stroke was if they developed basically functional deterioration that was thought to be due to a vascular origin. So what were the results of this study? So first of all, how did they define what an abnormality on the CTA is? So they came up with this metric, which they called CT-CTA positive. And so what that included was signs of an acute ischemic event on the plain CT head, which we kind of already talked about a bit. And then also intracranial or extracranial vessel occlusions. And then finally, stenosis equal to or more than 50% in the brain. And so if we look at some of the results of this study, you could see a number of different things. So first of all, patients that had this CT-CTA positive metric had an increased risk of recurrent stroke with a hazard ratio of 4. If we look at comparing the intracranial occlusions or stenosis combined together versus the extracranial the extracranial carotid occlusions or stenosis, you can see that both of these factors had an increased risk of recurrent stroke. So of note, it's not just the people with narrow carotids that are having strokes, it's also people that have intracranial occlusions or stenosis that are also having recurrent strokes. And finally, they also looked at the CT for signs of acute ischemia. And as you can see, it's fairly... So unfortunately, those results didn't achieve statistical significance, which is interesting if you're comparing it to the newer study that was done with those other patients. But still, you can show that there's an effect favoring acute ischemia on the CT as increasing your risk of recurrent stroke. If we look at these results on a Kaplan-Meier curve, which was done in the patients, you can see that it was divided into, again, this CT-CTA positive metric versus CT-CTA negative metric. You can see that the curves separate out, and they do this quite early on. So the authors actually found that the median time to an event in this study was just 1 day. So basically, patients that had a positive CT-CTA were having more recurrent strokes, and these strokes were happening very early on. There were some limitations to this study. So 2.2% of the patients in this study were lost to follow-up. 12% of the follow-up in the study was done by phone. And most patients were actually admitted, which is very interesting because this isn't something that we would do at our center. But actually, like, the vast majority of patients were admitted. And the authors actually state that they were using then later on the metric of a CT-CTA positive in order to keep patients admitted, but patients that had a negative CT-CTA towards the end of the study, they started discharging home. So they were actually using the imaging to risk stratify in that way. So what about vascular imaging here at the Ottawa Hospital? What are we doing for vascular imaging here? So the general principle is that patients that are at higher risk after having a TIA, should have a CTA prior to leaving the department. And this is because we want to, again, look at the carotids. We want to do this early on, quickly, right away, know the answer. And then we also are interested in some of the intracranial vessels to know if there's significant abnormalities there. And so the kind of policy that we're operating under now is that how do we determine who should receive carotid Dopplers and who should receive a CT-CTA? And so the answer to that is patients that have motor symptoms should receive the CTA, and patients that have speech symptoms should receive the CTA. And so when we say speech symptoms, it's not just patients that have episodes of aphasia, like it includes dysarthria, it also includes any kind of language disturbance. And I thought I'd also just put this up because I know that this has been changing quite frequently in CPOE. It seems like we're always trying to figure out exactly what imaging test to order if we want to order a CTA. So I saw Christian ordering one the other day, and actually it's been relabeled something that's quite intuitive. So now it's quite easy to know what to order. So it's actually called a CT angiogram head and neck. And so this brings us to our last kind of point of the talk, or last thing that I want to discuss. And this is like which TIA patients should actually see a neurologist in the department before going home. And so I was asking Dr. Stotz this question, and he had a few different thoughts on the matter. So he thought that patients that have an acute stroke on their plain CT head in TIA patients should probably see a neurologist right away, so like that day, because they could probably benefit from assessment by a neurologist. Patients that have a CTA that shows a free-floating thrombus should be assessed by a neurologist in the department, because sometimes these patients will actually be started on a heparin infusion. Again, I'm not going to get into that, but that's just the policy here at TOH. And then patients, obviously, that have a carotid stenosis over or equal to 50% should be seen by a neurologist, and also by vascular surgery for consideration of a carotid endarterectomy. And so what's very interesting is that these indications, the vast majority of these indications for seeing a neurologist in the department are based on imaging, actually. They're not really based on the, the ABCD2 score and things like that. They're actually based on some of the imaging findings, which is interesting. So if we look at our TIA bottom line, so in patients that have a clinical diagnosis of TIA, you should do a CT head. That CT head will either show an acute infarct or it will be normal. In patients that have a CT head that shows an acute infarct, these patients should see the neurology team in the emergency department. And if the CT head is normal, then you should risk stratify patients. So how are we going to risk stratify patients? So those patients will either be high risk or low risk. And that risk stratification is done with, if the patients have motor or speech symptoms, they're determined to be high risk. The low-risk patients, we can do what we've always been doing and send these patients home, arrange carotid Dopplers, refer them to the stroke clinic, decide if they should be on antiplatelet agents. And then the high-risk patients, these are the patients that we want to identify in the emergency department, and these are the patients that we want to have a CTA performed. That CTA will either be positive or negative. If that CTA is negative, and again, by negative, I'm talking about the metrics that was used in that study, so meaning that there's no significant intracranial occlusions, the carotids look okay, that patient can be discharged home with stroke clinic follow-up, again, with consideration as to whether or not this patient should be started on an antiplatelet agent. And then the patients that have a positive CTA should be seen by neurology in the department. And so I wanted to leave kind of a significant amount of time for questions because I thought that some of these things might be a bit inflammatory or